Hey, everybody, welcome back. Teresa Youngstrom with a better approach to memory care. We're so glad you're here. On this podcast, we try and talk about things that are going to be of interest to you, and we try and interview people that bring their gifts and talents forward and share them with so many people so that we can, add to what you're doing at home already with great information. And we didn't let you down again. Today, we have Dr. Brittany Lamb with me. Let me read her bio. It's really impressive. So I've been following her online and have even gotten into some of her sessions of support group. And let me just tell you, so worthwhile. Dr. Brittany Lamb has been practicing as an emergency medicine physician since 2014. Working in the ER, she grew frustrated witnessing the overwhelm and stress that goes with decision makers, their need to speak for someone that they care about. So real. Recognizing the unique challenges that come with medical decisions for people living with dementia, she decided to share her expertise beyond the walls of the hospital, and I'm thankful she did. Now, Dr. Lamb also works online to empower medical decision makers with the knowledge and the tools that they need to make informed choices through free and paid resources. Dr. Lamb lives and works in Northern Virginia. Her time is spent flipping between the ER at night and her online and hospice work during the day. Downtime goes to spending quality time with friends, family, and her husband. Please help me welcome Dr. Brittany Lamb.
Hey, thank you for having me, Teresa. I appreciate it.
Of course. And I just find you relatable. I was an ER nurse for a season of my life and really appreciate people who can work in that area because it is very trying. And so thank you for taking the time out of your busy schedule to be here. But the fact that you have all this knowledge about dementia too makes you just highly qualified to come on our podcast and share. We have lots of individuals that are caring for other people and really need this information. So let me get to my questions. There's a lot of good stuff
Okay.
here.
All right.
So first, let's see. So I put on here, I appreciate your work assisting people, caring for loved ones from the beginning. I've just appreciated you. For those who have not seen your work, tell us about some of the situations that led you to educate in this area.
Yeah. So I've been now working exclusively in the ER for about 10 years, between training with residency and now as an attending. And I just find I take care of a lot of people who are aging. So that's a big majority of the patients that I see. And I find that people over rely on paperwork like advanced directives, thinking that that paperwork is going to tell us what to do. And in a lot of instances, it doesn't. And I find that a lot of people rely on their family members to be able to know what's okay, what's not okay. And they're not prepared. They're not prepared. They're not informed. They don't understand necessarily, not that it's their job to, but understanding the medical like ins and outs of what's okay and what's not okay. And it's just all more complicated for people who are living with dementia because at some point they lose the ability to make medical decisions for themselves, and they're routine decisions, not necessarily like end of life decisions. I think that people plan more for that and they miss this whole middle section of time. So I know it's super stressful to make our own medical decisions. And so if you're having to do that for someone that you love, respect, want to honor and follow their values and preferences, it's hard to do without a lot of information and education, which we do not have time to give people inside of our crazy dysfunctional healthcare system. So that's kind of the reason why I came online.
Yeah, well, I appreciate that. And for a lot of people, I mean, the ER or just the hospital in general, that's not intimidating to me because I spent so many years of my life there. But for a lot of people, that's so frightening,
Yeah.
and gosh, to know what paperwork to bring, there's so much more to it. So, how
Yeah.
important is it for family members and care partners to bring the appropriate paperwork to the emergency room?
Yeah, so I think that it is important. It definitely it depends on the family dynamics and who the medical decision maker is. Spouses are typically not questioned as often because in most states, like that's the default decision maker is the spouse. But when there's multiple children involved and, perhaps they've all been named on a document, then we want consensus between those people. Um, it is important to have paperwork. The most important paperwork that you can really bring is telling us who the person wants to speak on their behalf when they can't make their own medical decision. So that is a type of advance directive, and what that title is different in every state. So medical power of attorney, healthcare surrogate, healthcare proxy, those types of things. I do think that having that paperwork on file with the hospital, if your person doesn't travel that often and they typically just go to one hospital system, which is really what's best for people, it's better to have that stuff on file. That way it's there. But I think having a copy of it is a good thing. And then if you have advanced directives that talk about what type of care preferences a person has, it's not a bad idea to have those on hand. But like I mentioned before, they're not always going to tell us what to do. They typically talk more about what to do when someone is at the end of their life, or if they're already receiving like maximal medical management, like say they're in the ICU and care is just not really working and now we're trying to figure out what's okay. That's
Right.
typically when I find advanced directives more helpful. The other forms that you would want to bring would be medical order forms like a do not resuscitate or a pulse form.
Mhm.
And those are different. Those are not advanced directives. They're
Right.
different than, so
Maybe go
that's
ahead and
kind of the highlight.
explain POST is kind of a new thing for a lot of
Mm,
people, and in some
yeah,
states, I think they call it MOLST,
yeah,
but, yeah, maybe elaborate on that a little bit because th
yeah.
that's really important.
Yeah, so it's a medical order form. It's an expansion of the do not resuscitate form. That's how I usually tell people to kind of think about it. It's signed by a medical professional, and then when it's signed by that medical professional, it's an order that everybody else can follow. So paramedics can follow it, the ER doctors and nurses, like everybody who takes care of this person. It should go with the person wherever they live. Ideally it's uploaded in a database, but then also physically it's important to have it on paper. So it doesn't just talk about CPR. And I think, the do not resuscitate form, yeah, a lot of people should have a DNR. They should have a do not resuscitate form when that's what their goals are. And it's appropriate from a medical standpoint. But Pulse tells us outside of a situation in which someone would want CPR, what type of care they would want, and kind of helps us communicate their goals of care. So if they're actively dying and they need CPR, because that's the only time we do CPR, when someone doesn't have a pulse and they're not breathing, they get chest
Right.
compressions and taking over their airway. But if they're not actively dying, do they want to go to the ICU? Would they like to stay out of the ICU, but they're still okay with being in the hospital? Or would they want care that's more focused on comfort? That document, it's different in every state. Not every state is using it either, which is the other thing.
Mhm.
Like you mentioned, Pulse is one name, and that's where it started from. It started as Pulse, POLST. But other states call it MOST. I've also seen MOLST and POST as well. So, but basically, it's just an expansion of the do not resuscitate form, allowing for more documentation of someone's goals outside of just their preference for or against CPR.
Right, because
Um,
it includes feeding tube or, do you want chest compressions? And, I think it's so great that people have, that they're able to communicate all those other wishes.
Yeah. Yeah, it's important and it's actionable, and that's the difference too between that and advanced directive. So an advanced directive like a living will or healthcare advanced directive, we have to read that and interpret it. And paramedics should not be responsible for having to do that in real time. So a post form is like immediately they can read that and say, oh, okay, this person doesn't want to be put on a ventilator, or this person doesn't want us to do aggressive things to treat their breathing. They want comfort focused care, for example. So it's an actionable document that doesn't require as much interpretation. So it's very helpful in the real world.
Right.
Um,
I'll
yeah,
never forget a couple of daughters, their mom had come in under life support, and one of them saying, she wants all this intubator," and the other daughter's going, she doesn't want this," and we're like, "What a terrible
yeah,
situation to be in." And so, yeah, just encouraging families to go ahead and get this stuff done. It's just
hmm
so important. I know I'm preaching to the choir because 'cause you're forever telling about this and I am too. It's like, "Please get this paperwork done and have copies available," and those
yeah,
sort of things. So
yeah.
I find it beneficial for care partners to stay with their person in the ER. What's your opinion about this?
Oh, absolutely stay. If you can stay, it's super helpful. I mean, and it depends on what stage of disease a person living with dementia is in. People who are in the earlier stages, it's oftentimes not noticeable to medical professionals that they are living with dementia. And so they may do fine, but as someone progresses in disease, like they're going to need help communicating. And the other thing I like to remind people about is that a person living with dementia who gets sick or injured is going to have more trouble making medical decisions than someone who is not living with dementia who gets sick or injured, who may also struggle to make their medical decisions. Like any one of us may have that issue if we're really sick or we're injured. But a person living with dementia, even if they're able to on a good day make their own decisions, that doesn't mean that that will be the case in the hospital setting. You need an advocate in the hospital. It's super busy and fast paced these days. Like everybody pretty much should have someone if someone is available to be with them. That's my opinion.
I agree
Um,
100%. I'm so glad you
yeah.
feel that way. I agree 100%. Can you share a story from the ER where a situation went the wrong way and how we can prepare ourselves for a safe and productive ER visit with our person living with dementia?
Yeah, so I mean I have lots of tidbits for this, but I feel like for me as a physician, I advocate that people plan for the most likely medical decisions that they're going to have to make on behalf of their person living with dementia. I call this medical decision planning. So instead of planning for end of life and whether or not someone wants a feeding tube or CPR, which are things that we should talk about, I think it's more important to look at what is the person's individual risk? Like, what are the medical issues that are most likely going to happen to them that are going to put them in the ER? And then let's talk about what that care looks like and what's okay and what's not okay now. And then what might be okay or not okay in the future, depending on their values of quality of life. So, I had this family one time. It was probably a couple of years ago now. Um, I, it was a daughter who was advocating and speaking on behalf of her father, who's living with Parkinson's related dementia, who was living in a care facility, got really sick. He had a urinary tract infection and was becoming septic from this. So severe infection. I know you know, but for anybody who's listening,
Yes.
this is a severe infection where your whole body's kind of responding to this infection, and it can make your all of your organs not work the way that they should, basically.
Including your
So,
brain.
including your brain. So yes, he was more confused. But he was having problems. His blood pressure was low. And, we were getting to the point where I had already given him as much fluid as I could give him. And now we're starting to talk about like, okay, we might need to go to the ICU. We might need to start pressors. These are medications that artificially raise the blood pressure. So, his daughter was like, I know he would say that he's been living with poor quality of life. He wouldn't want us to try to prolong his life just for the sake of prolonging it. He would want comfort, focused care. And she's like, but I need to talk to my brother. So she's calling her brother and he's not answering. And so, she and I basically wound up putting him in the ICU, starting life prolonging care because she was unable to get a hold of her brother. But but she was like crying because she knew that that's not what her dad would. And so like these are example like this is one example of what happened to this man was foreseeable. This
Yes.
medical problem he had, we know these things happen. We can absolutely prepare people ahead of time for how to make these decisions as a family, and including the person if we can, ahead of time so that it's not as emotional. And the other thing is the strategy about when there's multiple decision makers. This daughter had a good relationship with her brother. And I even asked her, I'm like, do you think your brother would be mad at you? Do you think that your relationship is going to be impacted if you make this decision without him? And she said no. And so it's just so interesting. And like, I just, it's frustrating as a doctor to do things to people who I'm being told wouldn't want them
Right.
because of other issues, and when all of it could have been planned for and decided kind of ahead of time. So
Right. And alleviate the guilt
yeah,
that I've seen a lot of family members go through afterwards.
yeah,
The guilt that maybe they made the wrong decision. But if we had discussed it,
yeah,
then there's great comfort in knowing that you are following their wishes.
mhm,
Wow. Wow. I'm sure you see that
yeah,
a lot. I'm sure you see it a lot. Well,
yeah. I do, and I, as an ER doctor, I know you being in the nurse in the ER as a nurse. you see some of the same people come back. You get to see the same families sometimes, and you get to see that the way that they second guess themselves or they regret the decisions that they made before. Um, and so yeah, I think that medicine and making medical decisions, it's not often black and white. It can be very gray, but there's a foundation of knowledge that if people have, they will feel so much less overwhelmed and stressed and feel guilty in the moment making these types of decisions. There's just basic like medical information that people need, which is what I've tried to bring online.
Right. And I remember talking with a gentleman in his 90s about his advanced directives, and
Mm,
he definitely wanted everything done. He said, "No, I want everything done." He said, "And then after a few days, if it doesn't look like I'm going to make it, you can turn that stuff off." But it was
mm.
just interesting because some people are like, "No, I don't want chest compressions. I don't want intubation. I don't want any of that." And yeah, but it was just interesting, and we could follow his wishes. That's he wanted the CPR and the intubation, and that's what we would do. So just
Yeah.
so interesting. Okay. With your work split between ER and hospice, I'm sure that you would have some people living with dementia live a very long life. So let's see, do you have advice on when the family should seek the hospice care?
Yeah. So, um, I think that if a person values quality of life and they would judge their quality of life to not be what they would be acceptable with, that they would not be happy with the way that they've been living, that they would prefer to stay out of the hospital pretty much at all costs.
Right.
I think that's when you want to start thinking about hospice. Now, you have to meet criteria for hospice, and we have to say, well, it wouldn't be surprising that this person passed away within the next 6 months. And so you have to meet criteria. In order to stay on hospice, you have to show that you're declining over time, in order to justify Medicare continuing to
Is it
cover
still
the
at 90
cost of
days?
hospice.
Is it still every 90 days they assess you? What's the
Yeah,
reason?
typically,
Okay.
yeah, and I'm new to this world, and so, but yes, I've been seeing patients like pretty much every 60 to 90 days, and so I think it has to be goals of care. So our goals of care need to be focused on comfort, and preferring to stay out of the hospital. And then also we have to be more towards end of life. If those things are not there, I think palliative care is the kind of where I would go next. And I think there's a lot of issues with palliative care. There's reimbursement issues, so it's not provided as often. There's a lack of access to it in a lot of places. However, if you have access to it, it's definitely a good resource. And just because someone's under the care of palliative care doesn't mean that they can't go to the hospital, that they can't be in the ICU, that they can't be on a ventilator. Like they can have every medical care that would be reasonably available to them, that would be beneficial to them, unlike hospice. And hospice is comfort focused care. So palliative care is just to help you get care that goes in line with your goals. And so anybody who's living with a condition who we know that condition is going to impact their quality of life in the way that they live day to day, palliative care should be considered, and talked about, especially if it's an option as an outpatient, so outside of the hospital.
Yeah, I think there are lots of opportunities where it would be beneficial and bring one more resource to that family.
Okay.
They probably have access to a nurse and social worker and, different things when they just get palliative care. And I think people need to understand too, if your mom or dad is under hospice care and they fall and break their hip, they can still go to the hospital. We
Yes.
can still stop the hospice, treat them, and figure it out.
Yeah. Yeah. And it depends on the medical situation. Like you may not even have to revoke hospice,
Okay.
So it just depends on the medical situation because it's about comfort. So if their comfort needs cannot be met where they currently are living, then they should come to us in the hospital and let us help.
Hmm.
So
Yeah.
yeah.
And hopefully we discharge them back home. Hopefully.
Yeah. Yeah. Or sometimes people have to go to rehab. Or there's even like inpatient hospice houses that someone could transition to as well. So the hospital is there as a safety net. So even sometimes people who are under the care of hospice in their home or in a living facility do come and see me in the ER, and sometimes they do stay in the hospital.
Right. And that is good. That is good to know. Um, As you're doing these support groups for care partners, for their loved ones with dementia, what do you think some of the biggest worries are? What are the biggest questions or most common questions you're getting?
Yeah, I think, well, honestly, like some of the most common things that people really struggle with are day-to-day caregiver needs and how to deal with the behaviors and the changes in the person on a day-to-day. And that's not my area of expertise. That's why I refer people out to all different people that I meet, like you, like other people doing this work. But from a medical standpoint, I think people want to know how to know what's okay and what's not okay. And it's complicated and it depends on the person's individual values and preferences and what they would say about what quality of life means to them.
Yeah.
And so that's why I've developed a way to help people actually create decision plans ahead of time, to kind of deal with that. And people don't realize that that's what they need. But they're wondering, how do I know what's okay and what's not okay? And how do I know when it's time to choose potentially less invasive care because my person cares about quality of life? Those are really the most common struggles. So yeah, those Q&A sessions, we talk about all kinds of things. So I do them typically like twice a month on Zoom.
Mhm. Yep, I've
So,
been
but
on
yeah,
there. I've been on there and was impressed. It's been fun.
yeah,
To
all
get
kinds
on
of
there.
things come up. But I think like from what I do and how I help people, those are like the most common things that people are wondering.
Right. Maybe if we back up, I'd love to hear you just explain the difference between palliative and hospice care. I think there are a lot of people that really don't understand that.
Yeah, so hospice care is for people who are at end of life. We would not be surprised if they passed away within the next 6 months. And their goal of care should be that we want to focus on comfort and staying out of the hospital. Um, Palliative care is really care for a person who is living with an illness that's going to impact their day-to-day life, their quality of life. And the purpose of palliative care is to make sure that that person receives the type of care that they would want now and into the future. So it will help change care if this person values quality of life and at some point would want comfort focused care. So I think the big difference between palliative and hospice is that, and people don't, even doctors do not understand this, is that palliative care is not about end of life. It's about making sure the person receives we call it goal concordant care. So it's care that they would want that goes in line with their goals. But it's both of them are like a team of people typically that help this person and their family navigate the illness that they have. But hospice is for the last 6 months of life. It's for someone who's more towards end of life. Palliative care can be done at any point. And I recommend palliative care to every person who's living with dementia, and their family to look into that and see if it's available to them because unfortunately it's not widely available everywhere.
Right. It is available here in Cincinnati, thankfully. The other thing that's interesting is you can graduate out of hospice.
Yeah.
My mother graduated out of hospice, even though she was bedbound, was a non-weight bearing, Hoyer lift to get her to her wheelchair, and needed assistance being fed sometimes, but she stabilized.
Yeah.
She
Yeah.
stabilized, and we did miss them when we didn't have them there for a while because the benefit of having the nurse come out each week and sit down with
Yep.
my parents was so cool. It was so good for my dad, and then having the aide come out 3 times a week,
Mhm.
helping with hygiene, and then the amazing supplies that they provided.
Mhm.
It was a really wonderful service, and so I want people to not be afraid of that and not wait too long to get the
Yeah.
service.
Yeah. No, I totally agree. And it is I honestly have a really hard time sometimes when we do have to discharge people for medical stability because their goals of care are still aligned with hospice and they still are living with a terminal illness. It's just that they haven't declined enough that we can justify keeping them. And that's all government regulations, and that's people being concerned about like the whole entire company not being able to function because we've been audited and they're concerned that we're keeping people that don't meet the criteria. So I think there's some overhaul that's needed in how to provide more access to palliative care and hospice, and then also making some exceptions for people who are clearly like what you're describing with your mom. I mean, it makes sense for someone who's living like that to be under the care of hospice. But you're right. People do have to come off of it because we can't unfortunately justify to the regulators that they stay on. And then
Yeah.
they can go to another company. So sometimes that's what happens too. Is people leave one company and they go and find another one. And then that company is like, okay, yeah, you meet criteria. I'll take
So it starts over. The period
it.
starts over.
Yeah, I mean, well, we still know like how long that they were with hospice
Sure.
prior, but yeah.
Sure. But a new assessment comes in and
Hmm.
maybe they find enough criteria, some skin breakdown or whatever else it might be that might qualify. That's interesting.
Yeah, and yeah, so I don't know. I have a lot of I have a lot to say about that.
Yes. Yes, absolutely. Um, from bringing my person living with dementia to you in the ER, what's your best advice? Just tell me what I need to do, and what I should plan for while I'm there, because I can be there a while.
Yeah, so I mean, it's based. I actually have a whole entire blog article on this, like how to make an ER visit less stressful, and maybe two parts of it. I've written like 20 something articles. If you go to blambd.com/blog, but it's simple. It's like know what you're trying to ask, like what the question is. And sometimes it's very obvious, like my person's having trouble breathing or they're in severe pain. That's separate. But like if you're like my person's acting weird and I'm wondering if they have a urinary tract infection or they have this medical problem in the past that caused this, I want to know like what's going on. Make sure that the staff knows that your person's living with dementia, and don't assume that the staff is all talking to each other, because there's techs, there's nurses, there's shift change, there's doctors, and like we're all running around doing our own jobs, and we don't always get to sit down and actually talk about the patient that we're all caring for. So it's like know what your goals are and what you're trying to get out of it. Ask for what you need. Like I need to talk to a social worker. I'm struggling. I really can't take my person home. Like it's so helpful to know that ahead of time. Like that's our goal right now, is to try to find something that might be able to help us help you.
Yeah, get those balls rolling. Yeah, absolutely.
Yeah. And then come with the medication list that's accurate and up to date. And if you know your person's goal of care overall, like are we trying to prolong their life? Are we trying to focus on quality of life? Are we trying to focus on comfort? That can be extremely helpful in knowing what tests we should run, what we should do, what we should not do, how many times we should stick them to get an IV, do we need to cap them to get a urine? Like it helps us make so many decisions, and most people don't come with that knowledge. Because the doctors and the healthcare system is not set up to help you all as surrogate decision makers, like determine these things when your person's no longer able to weigh in anymore. And so that's why I am here to try to help people do this, and you can consume my resources for free and piece these things together, or you can become a client of mine inside one of my lower price programs or my more higher price program. So
Right. And anywhere in the United States or anywhere people can participate in that.
yeah. Yeah,
Yeah.
it's for any. I mean, I have had a few people. I have someone in Canada, um, and some of the documentation that we use is different, but the medical stuff that happens to people is exactly the same. So,
Mhm. Tell us more
yeah.
about those programs.
Yeah, so I just released in the winter of 2024, I just released a program called Medical Decision Making 101. It's for dementia caregivers. It's basically how to be a medical decision maker for someone living with dementia, how to figure out goals of care, and then it teaches the process for creating a medical decision plan. That's $97. It's a one-time fee. It's videos and a book that goes along with it.
Nice.
And then I also have a program called Make Your Plan with Dr. Lamb, and that is a more comprehensive program because it has each medical condition that someone living with dementia is at risk for because of dementia. I teach a video on that. And
Nice.
then also emergencies that happen to people as they're aging and how to assess your person's risk and figure out what they're at risk for. That's inside of Make Your Plan with Dr. Lamb. So Medical Decision Making 101 is like 90 minutes. Make Your Plan with Dr. Lamb has about 13 hours of content in it.
Mhm.
And I guide people through what they should pay attention to. So I teach them how to organize their person's medical history and tell me what I need to know in order to help them. And then I analyze it. So I tell them, like, these are the things that you really need to pay attention to with their medication. These are the decisions that you're most likely going to need to make. And this is what I want you to focus your time on now. And then in the future, we can move towards like thinking about these other decisions. So I basically like open the course and tell them what to really pay attention to. So that program is $697. It's a one-time fee as well. So they have access to it for forever.
Yeah, incredibly valuable, though. I can see how all those resources would just be lifesavers for families who don't know what you and I know, and what it's like to come into the ER like that and to
Yeah.
be caring for someone. It was a decade of decline with my mom, and boy, did I learn a lot. I don't know if I told you this, but I got thrown out of the blankety blank house. I thought I understood dementia and that you're nice to them. And I had been a director of a memory care, but
Mhm.
when you're not a family member, they're more likely to be cordial to you if you're nice, and they'll use that cordial ability. And so I got along with people quite splendidly until my mom kicked me out of the blankety blank house. So it's always different with your own parent. And so I am so thankful you have all these resources for people. This time has gone very fast. Okay,
Mhm.
so before we wrap up, I really want you just to elaborate on how my audience can get in touch with you, because I know many of them are going to want to get in touch with you. And we can also put information in the show notes. So thank you. Thank you so much for being
Yeah.
here. And please elaborate to my audience how they can get in touch with you.
Yeah, I think the best thing is just to sign up to receive my emails because then you'll get invitations to come to the Q&A sessions. Those are all for free on Zoom.
Very
And
valuable.
then yeah, and then like as time goes on, you'll learn about my programs and you can see whether or not they're a good fit for you. And you can also ask me questions. So you can ask me questions at the Q&As, but you can email me as well. So it's B Lamb, my first name is Brittany. So blambmd.com/email. And then you just put your name and your email address in there and you'll be added. So that's probably the easiest way.
Yeah. And listen, everybody, you are going to love this information. Please be sure and check it out. Thank you so much, Dr. Lamb, for being here today and being a guest. I so appreciate you, and I'm excited to get this information out to the masses because they need this information. So thank you for all you do. Well, everybody, there you've heard it. And I know we could have gone on and on because there's probably a lot more information there, as you can tell. So go to her blog, go to her website, send an email so you can get on the mailing list, because there are treasures waiting for you, treasures of information that'll help you so much. Like I said, I've been receiving these emails, and I've been able to get onto her Zoom, her support groups, and listen in. And such great information. I just knew I had to bring her to you and have her on the podcast. So thanks again for being here. Be sure and like, share, and subscribe so we can help more and more people. And you know what? Just always keep in mind that I believe you got this.